So let's see how prevention of mother-to-child transmission is done, and we have several examples that we'll be sharing today and more tomorrow. And I'm going to turn it over now to my colleague Julie Lazaroff, who's the Perinatal Hepatitis B Coordinator for New York City Department of Health and Mental Hygiene. Julie?
Thank you, Dr. Ward. Can you hear me? Okay,
Yes.
great. So good afternoon, everyone. And my name is Julie Lazaroff. I'm the unit chief in the Perinatal Hep B Prevention Unit here at the New York City Department of Health, and we are housed in the Bureau of Immunization. Today, I'll be speaking about perinatal hepatitis B prevention in New York City. Next slide. Thank you. So the Perinatal Hep B Prevention Program is a national grant-funded program supported by the National Center for Immunization and Respiratory Diseases at the Center for Disease Control and Prevention, and this program has been in place since 1990. The central mission of the program is to prevent perinatal hepatitis B infections. The program has 4 central objectives: to identify hepatitis B positive pregnant and postpartum patients, which we call cases, through public health surveillance methods; to ensure administration of newborn post-exposure prophylaxis, which consists of the hepatitis B vaccine and the hepatitis B immunoglobulin within 12 hours of birth; to conduct follow-up timely completion of the 3-dose Hep B vaccine series by tracking vaccinations and working with pediatric providers and families to ensure that appointments are scheduled and kept; and then finally, to provide case management to ensure that post-vaccination serology testing for hepatitis B is completed on time and to monitor the infant outcomes. And next slide. So the first objective, to identify pregnant patients with hepatitis B, is supported by multiple public health requirements and recommendations. In New York State, including New York City, Public Health Law 2500E was established in 1990, and it requires prenatal screening for hepatitis B surface antigen, which is the most reliable indicator of infection, and reporting to public health hepatitis B infected pregnant and postpartum patients. It also specifies that prenatal providers record the test result and date of collection in the prenatal record so that it is available at the time of delivery for staff to review, and this is for all patients. Furthermore, patients admitted to delivery facilities with an unknown hepatitis B status are required to be tested immediately upon admission so that results are returned within 24 to 48 hours. Also, the maternal surface antigen result is required to be recorded in the infant chart as well as on the newborn metabolic screening form. The latter provision serves as a universal method to document the maternal Hep B status for all newborns, and positives are reported to the public health departments in New York State. So in addition to these legal requirements, over the years, other recommendations and development of more refined surveillance methods have been found to be important for the success of the work. The first is for the prenatal care provider to forward a copy of the original lab report instead of transcribing the result into the prenatal medical record, and this minimizes the likelihood of transcription errors. And in the same way, for the delivery facility to move the original copy of the lab report from the maternal prenatal record into the infant chart. Also, the CDC recommends that pregnant patients who may have been at risk for hepatitis B infection during pregnancy after their initial screening be tested again for Hep B upon admission. This includes patients who had more than one sex partner in the previous 6 months, were evaluated for an STD, engaged in IV drug use, or had a positive Hep B positive sex partner. And perinatal Hep B programs may also employ enhanced surveillance methods. Unfortunately, I don't have enough time to go into those today. And next slide. So this chart shows the number of births to Hep B positive birth parents reported to the New York City Perinatal Hepatitis B program and confirmed from the year 2003 to 2024. The range of annual cases is 545 to 1,978, with the highest number of cases in 2007. Since that time, the number of cases per year has been trending downward, with the lowest number of cases of 545 identified in 2024. And next slide. So this slide shows the hepatitis B vaccine birth dose coverage for all newborns in New York City from the year of 2013 through 2023. And it is similar to the national trend. However, the 2020 Healthy People goal was for 85% of newborns to receive the Hep B vaccine within 24 hours of birth. And the birth dose coverage in 2013, as you see, was 66%. And we did have some gradual improvement of almost 78% in 2019. But we have seen a decline since the years of the COVID pandemic, presumably due to some increase in vaccine hesitancy, that's not, I don't have a published study about that, but it has been a trend for all childhood vaccinations. And then with a birth dose coverage of 74% in 2023. Thank you. And next slide. So, through conducting outreach with high performing birth dose facilities and reading available literature on the subject, the New York City program has identified the following best practices for improving hepatitis B birth dose acceptance by families at the time of delivery. First, to provide education about the Hep B birth dose during pregnancy. And second, to remind the birth parent and other family members about the Hep B birth dose at the time of delivery. Then to offer the Hep B birth dose in labor and delivery or in the postpartum unit, and not to wait until the newborn is separated from the parent in a newborn nursery if possible. Also, pediatric providers should recommend that the newborn receive the Hep B birth dose inpatient and not wait for the first outpatient visit, and explain the rationale to the family. Also, inpatient pediatric providers should counsel families who are vaccine hesitant by listening to their concerns and providing evidence-based facts about safety and efficacy. Finally, if the family does decline the Hep B birth dose, the delivery facility should require the family to sign a declination form. And next slide, please. I will now discuss 4 case studies that occurred in New York City when maternal hepatitis B infection was not identified at the time of admission to the delivery facility, though the infants were case managed by the New York City program after delivery. In all 4 cases, because of a universal hepatitis B vaccine birth dose policy, all 4 infants did receive a birth dose within 24 hours. And next slide. Okay, so case study number 1, we had, this was where we had a prenatal surface antigen positive test result in the maternal chart. However, the maternal chart was incorrectly transcribed as negative to the newborn chart. Therefore, the newborn was not administered the HBIG. The Hep B vaccine birth dose was administered within 24 hours, and after being followed by the perinatal program in New York City, the 3-dose vaccine series was documented to be completed on time, and the child tested immune at 9 months of age. And next slide. So case study 2 is where we had, it was when a prenatal surface antigen result for a Hep B positive patient was unknown at the time of delivery. And the patient's prenatal medical record was unavailable at the delivery facility. This was actually during the COVID pandemic, and the expected delivery facility was actually dedicated to COVID patients only. So that patient had to go to a different delivery facility that did not have the prenatal record. The maternal surface antigen testing was the blood was drawn and was ordered at 24 hours after delivery, and the test result was unavailable at the time of infant discharge, though it was eventually reported as positive. The Hep B vaccine birth dose was administered within 24 hours. However, the HBIG was never administered because the family could not be reached. The perinatal program in New York City did follow up with the family and the vaccine series was completed on time, and the child tested immune at 1 year of age. So we have case study number 3. This was where the birth parent was surface antigen negative. However, they had elevated HBV DNA levels during pregnancy. This is referred to as an occult hepatitis B infection. The hospital protocol at this particular delivery facility is to, or was at the time, to only give HBEG to newborns if the birth parent is surface antigen positive. And this is very often the case where the protocol is to review the surface antigen test result because that is the test that's required during pregnancy. However, the birth parent and the pediatric provider knew of the birth parent's hepatitis B status, and they insisted that HBIG be given at day 2 of life when they discovered that the HBIG had not been given. The Hep B vaccine birth dose was administered within 24 hours of birth, and the 3-dose vaccine series was completed on time, and the child tested immune at 10 months of age. So finally, in case study number 4, this is where we had a case identified prenatally by the New York City Health Department, but the patient declined Hep B education from the health department staff. The prenatal surface antigen positive result, it was in the maternal chart. However, again, this one was incorrectly transcribed as a negative to the newborn chart. The New York City, the program contacted the delivery facility to inquire if the newborn had received the post-exposure prophylaxis, and the child was still there. And then upon questioning by the nursing staff, the birth parent insisted that they did not have Hep B. The Hep B vaccine birth dose was administered within 24 hours of birth, and then eventually the HBIG, after finding the positive test result by the staff, the HBIG was administered at 2.5 days of life, and then the 3-dose vaccine series was completed on time, and the child tested immune at 10 months of age. So quickly, to finish up my presentation here, I just want to walk through the recommendations to protect newborns against errors in identifying Hep B positive birth parents at delivery. So during the prenatal period, facilities should provide in-depth education to Hep B positive patients regarding the need for the birth dose and the HBIG to be administered within 12 hours. Also to instruct the pregnant patient to notify delivery staff of their Hep B status, as they do not always deliver at the expected delivery facility. At delivery facilities should administer a Hep B birth dose to all newborns to provide a safety net for high-risk infants, particularly if the maternal Hep B status is incorrectly recorded. And then to not transcribe Hep B test results from the maternal to the newborn chart, but to instead include a copy of the original maternal lab report in both the maternal and the infant charts. And then training staff on reviewing maternal Hep B test results, because the nomenclature can sometimes be confusing between the antibody and the antigen, and to have more than one person to verify the results, both in the labor and delivery and the postpartum or newborn unit, perhaps, to incorporate redundancy and prevent errors. And then where you have a Hep B surface antigen status that is unknown at the time of delivery, to always administer Hep B vaccine to those newborns within 12 hours, not 24 hours, within 12 hours, to test the surface antigen unknown patient's stat upon admission, not to delay. To ask the birth parent about their Hep B status if they know if they have a history of Hep B infection. And if there is evidence suggestive of maternal Hep B infection, that the newborn should be managed as if exposed to Hep B. For newborns with birth weight less than 2,000, uh, facilities are to also administer the HBIG by 12 hours unless the maternal surface antigen status is confirmed negative by that time, and if the birth weight is greater than 2,000, to administer the HBIG by 7 days or by hospital discharge, whichever occurs first. And that's the AAP, the Association of American Association of Pediatrics, or Also, if discharged, to document contact information for both the family and the newborn's pediatric provider, and notify the birth parent and staff that the surface antigen result is pending, and that's the CDC's recommendation. So, next slide, I just want to acknowledge the staff here in the Bureau of Immunization, Dr. Crouch and Dr. Rosen, and then all of the staff in the BOI's Perinatal Hep B Prevention Unit who have supported this work and to whom I am indebted for their support and all of their work. Thank you.
Thank you, Julie. We have a couple of questions. I'm going to get your response to, particularly the one relating to home births. There was also a question to start off with about the timing of hepatitis B birth dose and how quickly it can be given. And the answer is it can be given immediately after, birth. Thailand, for example, which has an excellent hepatitis B vaccination program, the median time between birth and vaccination is 40 minutes. Which and Palmer Beasley, who was the medical epidemiologist who did some of the early studies of hepatitis B birth dose vaccination in the 80s, I once asked him that question, and he said hepatitis B vaccine should be given at the time of the first washing of the infant. You wash the infant and then you vaccinate, and that's how quickly it can be given. You can comment on that, Julie, but I also was particularly interested on your practical experience with home births, and what are some of the options of assuring a timely hepatitis B birth dose as possible for those newborns?
Sure. So, we don't have a lot of home births among our caseload, so we just manage the pregnant patients who are hepatitis B infected, but we have had missed HBIG in some of those cases, even though there aren't that many. So I would say that the risk is higher. And also perhaps just a refusal of those patients to receive the Hep B birth dose, even if they're, among those who are not infected. Though I'm not sure, but just anecdotally. And the other issue is that to have the Hep B vaccine on hand is routine, even for you know midwives who deliver home births. However, the HBIG really would need to bring the newborn to the delivery facility. The good news on that is that can be given up to 7 days. But we've also had some issues with reporting. So the issue of home births comes up probably every 2 years at our river site visits, and there still hasn't been, a comprehensive outreach on, to those instances to the professionals doing those home births. So it's something that
Okay.
probably we should do.